lucky to have Dr. Yanis here with us this morning. And I'm going to ask Dr. Mena to introduce her. Thank you.
Morning, everyone. Thank you for joining Cardiology Grand Rounds. It's today my distinct pleasure and honor to introduce Fiorella Llanos as our speaker today. Fio obtained her medical school degree at the Universidad Cayetano Heredia in Peru. She then went to do her internal medicine at University of Texas Medical School in the Houston program. And then she joined us here at Yale in 2017 as a general cardiology fellow. Over the last 12 months, she's been working with me in the peripheral vascular program. I must say, I came to know Fio early on during her fellowship, and ever since, she struck me as one of the most hardworking fellows I had ever had the opportunity to work with. One of her patients once recently told me, you know, Carlos, that lady that you just sent to see me is the sweetest, more thorough physician I have ever encountered. And you should hire her. And that patient, many of us during her fellowship shared those feelings. When she joined the peripheral program, she met with me and highlighted her interests, both personal, academic, and we were able to develop a plan that I hope met all her expectations. From the clinical point of view, her work ethic, her professionalism, her bedside manner were unparalleled. From the academic point of view, she brought to light many projects that were dead, literally dead, and she was able to pull them together. And the most amazing thing is that she did all this while being pregnant. Catalina joined her family, and as she shared, since she was born, literally minutes after, she sent me a picture. That's one of the most amazing things that happened in our PV family. So, Fio, I am extremely proud.
Thank you.
I cannot express how I feel about you as a person and as a colleague. Certainly, in a time where interventional cardiology undergoes many, many changes, you represent what people describe as what the future will be, not only because of the things that I just mentioned, but also you represent a lot of different minorities. And the concept is very important because although the country is undergoing a lot of turmoil for many, many different reasons, you embody the women in interventional cardiology, the moms in interventional cardiology, the Latins in interventional cardiology. And because of that and many other things, I cannot thank you enough for your hard work. I cannot wait to see all your success as you evolve into the superstar that I'm sure you're going to be. With all that, I give you Fio and her wonderful Grand Rounds.
Well, good morning, everyone, and thank you for joining today. Thank you, Dr. Mena, for your kind words and just the support throughout the entire year. You have supported me through all my ideas. Many of them are crazy, including having a baby in PD, but I could have not done it without you. And Catalina and I are extremely grateful to you and our entire PV family for this. So I'm excited to present today, Saving More Than Just a Limb, Opportunities to Improve Quality of Care in Critical Limb Ischemia. And if someone 3 years ago would have told me that on my last day of General Cardiology Fellowship, which is today, and on my last grand rounds as a fellow, that I'll be talking about feet, I would have not believed it. But over the last year, I've learned that peripheral artery disease, it's so much more than that. So I'm excited to share with you all what I've learned over the past year and what I've worked really hard on. So with further ado, I'm going to start. There's nothing to disclose from the conflict of interest standpoint. This is an overview for today. We're going to start with some introduction and mention the challenges in the care of critical limb ischemia. Then we're going to take a closer look to a real world experience and highlight 2 projects that we have on the works. One in a complex scenario where CLI patients present with chronic kidney disease. And the second project on how to best manage antiplatelet regimen. We're going to finish with some take-home points. And so before we go down to business, when people think spend the entire year doing PV, this might be their reaction, but this has been far from my experience. Although I must admit that at the beginning, when I signed up for PV and then I realized I was pregnant, some part of me was like, oh God, what did I just got myself into? But soon enough, I realized that this is a very exciting field with very, very new things, new pathology, new patients, new procedures. So although sometimes you're a little bit tired, my overall take from this past year has been, I'm incredibly happy and grateful to have learned both medicine and procedures. I am extremely happy to have established new relationships with patients, many of which have been battling peripheral artery disease for many, many years. This is probably me after Dr. Mena allowed me to do my first carotid. And I'm just overall happy that I have formed great working relationships and friendships inside and outside the cath lab. So overall, Catalina and I are extremely grateful and on board and in love with PV. So now let's go down to business. What is critical limb ischemia? What does come to your mind when you talk about critical limb ischemia? Some people might think a little, almost harmless looking wound in the toe, but it can soon progress to a lot more extensive disease. And why do we care about critical limb ischemia? Why am I even talking to you today about critical limb ischemia? It's because patients with critical limb ischemia or CLI have a high risk of death. When you see here, the controls in green, symptomatic PAD in blue, and CLI in red, we can see that the survival of CLI patients is markedly decreased with about a 40% mortality in 2 years. And not only that, these patients also have an increased risk of limb loss, myocardial infarction, and ischemic stroke. So what is critical limb ischemia? Which from now on, I'm gonna refer to as CLI. It's rest pain and or tissue loss, either ulcer or gangrene, and some objective data of arterial insufficiency. It is also known as chronic limb-threatening ischemia and is the end stage of peripheral artery disease. There's many ways of classifying peripheral artery disease, and Rutherford classification is just one of the ways. It goes from 0 to 6, 0 being asymptomatic, 1 to 3 meaning claudication from different severities, and 4 to 6, it's CLI. It's important to notice that the higher the number, the more advanced the disease is, and the higher the number, the worse outcomes patients have. So in the spectrum of lower extremity PAD manifestations, the great majority of patients are asymptomatic. Within the symptomatic spectrum, the majority of patients have atypical symptoms. When we think of the typical claudication that we learn in medical school or even in residency, this is present only in 10 to 35% of patients. So we really need a high index of suspicion if we want to avoid progression to critical limb ischemia, which can be present in up to 10% of patients with PAD. So one of the challenges of treating PAD and CLI in general is the limited high quality data. And epidemiology is not an exception, unfortunately. So in 2010, more than 200 million patients or people worldwide had PAD, which represents an increment of almost 25% from the prior decade. However, in the absence of more contemporary data that will take into account increased life expectancy, changes in lifestyle such as decreased smoking, however, with increased prevalence of risk factors such as diabetes, the VAMOS program conducted a analysis from the National Inpatient Sample Database. We basically looked at PAD and CLI related admissions from 2011 to 2017 based on ICD-9 and 10-CM codes. And we found that both PAD and CLI are still on the rise. When we talk about PAD here on the left, the admissions increased from 1.6 million admissions in 2011 to nearly 3.1 million admissions in 2017. Likewise, on the right side, we can see that the CLI admissions are also on the rise, and it went from 300,000 cases to nearly 500,000 CLI-related admissions. So what are some of the risk factors that contribute to the development of PAD and CLI? Here are the ranges of odds ratio. And leading these risk factors are diabetes and smoking, followed by age, meaning advanced age. And then hypertension, dyslipidemia, non-white race, and renal insufficiency. Furthermore, this is an expensive problem to have. When we look at the Medicare expenditure in PAD and CLI, we noted that in a year, the cost is more than $4 billion. When we compare it to two other highly prevalent diseases such as heart failure or stroke, the expenditure for PAD is higher. It represents 3% of the total Medicare budget. And part of the problem is that most of this care is inpatient. There's a high rate of unplanned readmissions. More than 50% of these patients come back unplanned to the hospital within 6 months. And the cost per patient is high, with more than twice the cost from an average beneficiary. So this table summarizes how we manage PAD and CLI in general. There's non-pharmacologic interventions, pharmacologic interventions, and revascularization. Non-pharmacologic, we have a class 1 indication for both smoking cessation and supervised exercise program. On the pharmacologic arm, we have antiplatelet therapy. And it's important to notice aspirin or clopidogrel have a class 1 indication for symptomatic PAD. Aspirin plus clopidogrel after an intervention only have a class 2B recommendation, and that strives from, again, the lack of high quality data and randomized controlled trials. Statin also has a class 1 indication, and ACE or an ARB if hypertension is present. Now, we can revascularize these patients endovascularly and or surgically. And I'm not intended to go over which one is best and during these grand rounds. I think that's an entire whole grand rounds on itself. Just to mention that we have 2 ongoing trials, the BEST CLI and BASIL-2 trial, that are looking into answering this question. So another challenge that CLI patients face is the wide variation in management across the US. An example of this is the 2 maps I will present. The first one is of lower extremity revascularization rates, and then this one is of lower extremity amputation rates. The darker the shade, the higher the rates. And we can see that it's literally all over the place. Even within a state such as Texas, we have every single shade of color, meaning that depending on what part of the state you go, you might receive very, very different approaches. Likewise, from the amputation perspective. And this wide variation suggests that there's a differential recognition and treatment of CLI across regions that is out of proportion to the disease prevalence itself. Multiple factors may contribute to this, including patient awareness, physician knowledge, and identification of CLI and access to care. And although we have reasonable data in terms of amputation and revascularization rates, the data on process of care that can explain this shortfall and differences is still lacking. So now I'm excited to share what we've been working over the last year, 2 projects, with the first one being the treatment risk paradox for guideline-directed medical therapy, or GDMT, in patients with CLI and comorbid CKD. Some insights from the Vascular Quality Initiative, or the VQI registry. So why did we pick this population? Why did we pick the population with CLI and CKD? Because these patients are the sickest of the sickest with the worst outcomes. They have been traditionally excluded from trials, so it's little known about these patients. A lot of what we know about these patients is extrapolation from PAD or CLI data itself. However, there's a high prevalence of PAD in the CKD population, anywhere from 25 to 35%, but this prevalence goes even higher as the kidney function worsens. So when we talk about worse outcomes, we can talk about worse amputation rates, higher rates of myocardial infarction, higher rates of ischemic stroke, and higher rates of death. The VAMOS program just published this systematic review and meta-analysis looking into the impact of kidney disease in patients with CLI that underwent lower extremity interventions. And we found that patients with CKD or ESRD status had a higher odds ratio of amputations with an odds ratio of 2.27. When we looked into early mortality, defined as mortality less than 30 days from the intervention, we also found that CLI patients with comorbid CKD or ESRD had a higher risk of early death with an odds ratio of 3.1. So this makes you wonder if these patients are even living long enough to benefit from the intervention, if their odds ratio itself or the risk for having early mortality itself, it's much higher than patients with no CKD. There's many challenges to treat this specific population. They have atypical symptoms. They have a very complex medical, psychological, and social issues. They have complex anatomy. There's a limited use of non-invasive tests, either because they have a decreased sensitivity or because we have a limited use of contrast dye. And last but not least, there's a limited data of antiplatelet use. So now we can all agree that this is a sick, complex population, many challenges in the diagnosis and management of the disease. Therefore, the treatment of the risk factors is absolutely key. Dr. Erin Armstrong looked into the impact of guideline recommended therapy and cardiovascular outcomes and the association. And he reported that guideline recommended therapy was associated with decreased major adverse cardiovascular events, decreased death, decreased major advanced limb events, and decreased amputation or death. So we should be treating all these patients with guideline recommended therapy. When we talk about guideline recommended therapy or guideline directed medical therapy, it almost feels like the obvious decision, right? Some people will be like, yes, GDMT, or yes, UDMT. And some people will be like, of course, GDMT, duh, that's what like they go to. But how are we really doing in the real world? And we use the VQI registry to answer this question. The aims from this project were in patients with critical limb ischemia who underwent lower extremity endovascular revascularization. Our first aim was to examine the rates of GDMT prescription, both before and after an index procedure, and further looked at this by CKD status. And our second aim was to study the site variability for prescription of GDMT, also looking at rates by CKD status and adjusting for patient level and provider variability. But what is VQI? You know, I've mentioned it a couple of times now. VQI, or the Vascular Quality Initiative, it's a collaboration led by the Society of Vascular Surgery. It contains over 700,000 vascular procedures nationwide and in Canada. It contains demographic, clinical, procedural, and outcomes data. There's nearly 700 participating centers, and it collects near 500 patient and procedural level data in 14 major vascular procedures. We specifically use the peripheral vascular module to answer this question. There is trained data collectors who abstract the data and enter it from the medical records into the registry, and this includes a 1-year follow-up. VQI is a multidisciplinary subscription from different specialties. We can see this on the left-hand side. There's multiple specialties contributing to this, with vascular surgery being a major stakeholder. And it includes both academic centers in green and community centers in blue. So for this specific project, how did we define guideline-directed medical therapy? We defined it as the use of an antiplatelet, either an aspirin or a P2Y12 inhibitor, the use of a statin, and the use of an ACE or an ARB if hypertension was present. Now, our inclusion criteria was people above 18 years old with critical limb ischemia that underwent an endovascular intervention. And we included the first qualifying procedure. And what do I mean by this? Basically, one patient can have multiple peripheral interventions. We specifically picked the first peripheral vascular intervention. And we excluded those centers with high missing data and the interventions prior October 2016, since this was the time where VQI expanded the data that was collected. So we had more complete data and registry. Briefly, our analysis included descriptive statistics. And we compare patient characteristics and GDMT prescription both before and after an index procedure for the entire cohort, and then we stratified by CKD status. The prescription rates were summarized by site, and the distribution was plotted in histograms. There's a metric to express site variability, which is called the median odds ratio. So we use the median odds ratio to summarize the magnitude of site level variation of GDMT prescription. And we use a P of less than 0.05 as a statistically significant. So this is our flow diagram. We use, again, the PVI module, which is a peripheral vascular interventions module, with a bit over 178,000 cases or procedures. And after applying our inclusion and exclusion criteria, we end up enrolling a little bit over 27,000 patients. So I'm excited to share some of the results that we found. This is a somewhat busy slide, but let me just walk you through it. On the left side, you have the overall cohort, the non-CKD cohort in the middle, and the CKD cohort on the right. And these are percentages except for age, which is in years. As a baseline, the CKD group was an older group with a higher prevalence of comorbidities, such as hypertension, diabetes, smoking history, prior amputation, etc. They have a more advanced disease at presentation with a Rutherford 5 or 6 in most of cases. And they have a more complex disease of below the knee anatomy. So I'm gonna take some time to go over this table now, as it's one of the most important ones for my entire talk. On the top side, you have the GDMT prescription before the index procedure. And on the bottom, we have GDMT after our index procedure. Once again, the overall cohort on the left, the non-CKD group on the middle, and the CKD group on the right. And we can see that patients sent to an endovascular procedure before receiving this procedure, only 35% of our overall cohort was receiving guideline-directed medical therapy. When we looked into the subgroups, non-CKD patients received GDMT at a higher rate than the CKD group. And one will think that this is the perfect time to optimize these patients, right? You send them for a procedure. This is a perfect time to go over everything, review their medications, and optimize them if needed to be. And although there was an increment in GDMT prescription, this remained far from ideal. the overall cohort, we're talking that only 43% of patients after undergoing an intervention were on GDMT. Once again, when we look in the non-CKD group, the non-CKD group had a higher rate of GDMT compared to the CKD group. On average, the non-CKD group saw a near 10% increment in GDMT prescription compared to only 5% in the CKD group. So this is absolutely terrible. How we send all of these high-risk patients for these high-risk procedures, expose them to X-rays, dye, etc. We're not even prescribing GDMT, which we know it decreases their risk. We know it works. However, we're doing a terrible job. These are some histograms of the distribution of sites by GDMT prescription. On the y-axis, we have number of facilities, and then the x-axis, we have percentages of GDMT prescription, both before and after the procedure. In red, you have the CKD group, and in blue, you have the non-CKD group. The first thing you notice is that the CKD group have lower prescription rates compared to the non-CKD group in blue. But importantly, remember, median odds ratio, it's a metric to express site variability. And there was significant site variability both before in GDMT prescription, both before and after the procedure, which is reflected by an unadjusted median odds ratio of 1.3. So we just saw that patients with critical limb ischemia are receiving GDMT at a subpar rate. And furthermore, our high-risk group of CKD and CLI are receiving GDMT even less, especially compared to the non-CKD group. So what is treatment risk paradox? Is when patients at a higher risk profile receive less aggressive treatment, either medication, procedures, or surgeries. These treatment risk paradox have been described in other cardiovascular diseases, such as NSTEMI, where patients with a higher risk, despite the fact that these are the individuals that will benefit the most from guideline-directed management, they receive it the less. And this is the first time treatment risk paradox is being described in CLI patients with comorbid chronic kidney disease. So what can we learn from this first project? First, there's a significant underprescription of GDMT in CLI patients undergoing lower extremity revascularization procedures. Then there's a treatment risk paradox in those at the higher risk, those with CLI and comorbid CKD. However, with highly variable rates across centers, identifying factors that may inform quality improvement initiatives will be key to improve care and outcomes in this high-risk population. Our second project, we started working since last winter, and it's the use of cytochrome 2C19 testing in CLI, basically to evaluate for clopidogrel resistance. Just as a summary, sorry for the typo here, clopidogrel is a prodrug. Once you take it and it gets absorbed, it needs to be activated by the cytochrome 2C19 into the active metabolite. And there is a range of clopidogrel metabolism based on people's cytochrome 2C19 status. There is people that poor metabolizers that metabolize Plavix really, really limited to none. Intermediate metabolizers that metabolizes Plavix to a lesser extent, the normal metabolizers, and the ultra rapid metabolizers that metabolize Plavix even faster. So there are two retrospective publications in the use of cytochrome 2C19 testing in PAD and CLI. And although there's an abundance of data for CYP2C19 in CAD and the ACS world, there's very limited data in the PAD and CLI world. We know that so far, the two trials, or they're not trials, they are retrospective cohorts, have noticed that those with poor or intermediate metabolizer status have a higher amputation rate, seen in this graph, poor metabolizer status in purple, intermediate metabolizer status in red, and normal metabolizers in green. So those with intermediate poor had higher amputations and had worse survival. And they are also noticed to have worse patency rate after an intervention. So what about using other P2Y12 inhibitors? Unfortunately, there's only one prospective randomized controlled trial that looked into this, the Euclid trial, that compared ticagrelor monotherapy with aspirin monotherapy, with clopidogrel monotherapy. And it was found that ticagrelor was not superior than clopidogrel. But there's a caveat. This trial excluded those with poor metabolizer status for Plavix or clopidogrel. So we don't really know if second generation P2Y12s are the way to go in those with CLI or PAD and clopidogrel resistance. So in a joint effort with the pharmacogenomics group, we just finished a pilot where we tested all CLI patients admitted to Yale New Haven Hospital with a diagnosis of critical limb ischemia. Now, I want to walk you through where we are in the process and to highlight the direction we're hoping to go using pilot data in order to build a formal protocol that then will allow us for further efficacy training. So we just finished the pilot data, and we have preliminary data on outcomes before this pilot. We plan to start collecting outcomes after this pilot, and will help us understand if testing versus non-testing and genotype information can help us predict outcomes, or if they have an impact on a cost-benefit ratio perspective. It is clear that in PAD, there's not much known as how this testing will impact patient outcomes and resource utilization. This is an important gap in knowledge that we are trying to fill currently. So next, I'm going to share some of the pilot data, just to mention that in parallel of this CLI pilot, we are also running a CAD-ACS pilot. So this is some of the data we have collected so far. This is for Yale New Haven Health specifically. Here, poor metabolizers and intermediate metabolizers. And the prevalence of clopidogrel resistance in CLI, it's 45%. So 45% of our critical limb ischemia patients do not metabolize clopidogrel well. This is much higher than the 29% in the CAD-ACS population. When we compare to the literature, this is somewhat what has been observed before. So whether CLI population have higher risk of Plavix resistance and whether this contributes to disease progression, it's still unknown. So what are the next steps that we see for this project? We are aiming to build a multidisciplinary panel to develop a treatment protocol based on the available literature and consensus forming. And we'll look to prospectively collect outcomes in both major advanced cardiovascular events and major adverse limb events. So now let's round up with some take-home points. And before I go and go through the list of them, after this talk, after these grand rounds, we can understand that CLI patients are very complex. They have to be treated in a multidisciplinary approach. Not only, sometimes, we only focus on the revascularization, but we need to address their cardiovascular risk. We need to address their socioeconomic challenges, their wound care with podiatry, the infection. We need to work with our friends in nephrology, as this is a highly prevalent disease in CKD patients. We need to work with our endocrinology friends for diabetes management. And we need to manage all the other comorbidities. We need to work as a whole team, if you may say as a CLI team, in order to best serve our patients. So some of the take-home points: CLI population is a very high-risk group with potentially a lot to gain from this. GDMT is a proven cost-effective strategy to improve outcomes. However, this is largely underprescribed. Sadly, we're doing really bad at prescribing that, but even worse in our high-risk group. We have great pilot data about the use of CYP2C19 that would allow us to plan for a more sustainable care innovation. Whether modifying care will have an impact on outcomes or the cost-benefit ratio of this is still unknown. Last, we need to work toward developing protocols in order to prescribe evidence-based treatment while simultaneously working towards personalized medicine. This is a very long list of thanks. I hope I'm not missing anyone. First and foremost, thank you, Dr. Mena, for everything you've done for me and my family for the past year. Thank you, Dr. Smulderen, for taking down and help me rebuild my presentation over and over again. Thank you, Dr. Turner and Dr. Peixoto, for your constant support from the nephrology perspective. Dr. Avoyan, thank you so much. It's so important to work hand by hand with the vascular surgery team. Dr. Curtis and the core team helped us in our first project looking at the treatment risk paradox. The pharmacogenomics group and their invaluable input in our second project in the CYP2C19 use in personalized medicine. To my dear co-fellows who have put up with me for 3 years. To the vascular medicine program, my general career fellowship, Dr. Miller, Dr. Gandhi, the amazing coordinators, Corey and Kristen, to the entire section of cardiovascular medicine. Thank you, Dr. Velasquez, for supporting me and supporting this program. And last but not least, thanks to my family, to my husband, my parents, who have supported through the craziest ideas I've always had, including becoming an interventional cardiologist. This is a picture of our socially distanced PB meeting. This is the TARP program in ACC. This is my dear family when baby Catalina was born. She's so teeny tiny, you can barely see her. She's 4 months later, and this is on Father's Day. Special thank you to my co-fellows again, and good luck to those that have left Yale and are like Carolyn, good luck in your new job, as well as Krishna, who's probably flying today to the Midwest, Cecilia, who just arrived to Seattle, and Sumit, who's luckily staying with us in New Haven. I'm happy to take any questions now.
Fantastic grand rounds, Phil. Incredible tour de force on PAD and all the different projects that you have undertaken over the last 12 months. All of them have come from your own creation, and we're very proud of you. So if any of the faculty members have questions, please let us know.
Carlos, I have some comments and questions. Phil, great presentation. Congratulations on doing this great work.
Thank you, Trevor.
So I have a question on medications and goal-directed medical therapy. Mm-hmm. Is there barriers that you identified that preclude prescriptions? That's kind of question number one. Or like, is there any particular things that you identified in your research that decreases the prescription after interventions in the CKD population? And question number two, once the medications are prescribed, do you have any data on how well patients adhere to the medical therapy, say 6 months after intervention?
So those are great questions. First, BQI registry doesn't allow to see specifically adherence, to my knowledge, but some of the factors that have been proposed in the past as why these patients are not optimized is provider concern that of starting ACE and ARB after giving contrast dye, or when the kidney function is not normal. Provider concern that statins may have side effects, especially in the ESRD population, which that's why we excluded ESRD and statin prescription for our analysis. But in reality, it's a multifactorial problem. And I think the biggest issue is that us as interventionalists are not putting enough effort and enough effort and a systematic way to start these patients on guideline-directed medical therapy. When we talk about GDMT in heart failure, it's already very well established. They have a huge support from the clinical pharmacists. It's already very well known. I think it's a combination of lack of awareness and lack of a systematic way to optimize these patients.
Any other questions?
Carlos, if I may ask one more question on Plavix therapy, and specifically your pilot findings. Did they change your practice or how you prescribe treatment for the interventions you perform?
Yes. I didn't present that at this time, but it did change practice. The challenge is that this CYP2C19 testing has a turnaround of about 6 weeks. So that's one of the barriers that we're trying to work with the pharmacogenomics group. But once we receive the results, we will discuss it on a patient-to-patient basis. And basically, the poor metabolizers will all be switched to a second-generation P2Y12, mainly Brilinta, or ticagrelor, sorry. And the intermediate metabolizers, most of them got switched, mainly because this is a high-risk population and many of them had multiple reinterventions to the same limb and or underwent amputations. So just as an average, about 2/3 of the patients that had some sort of degree of clopidogrel resistance were switched to another agent.
It's Eric. First of all, congratulations. It's a wonderful example of how you could how fellows can integrate feasible, impactful studies within the very busy time of clinical training, and we need to see more of that. So congratulations for sharing these examples. My question for you is maybe one to educate me, but maybe has clinical impact, which is this group that you've shared with us, the high rates of critical resistance, particularly as it relates to CKD patients as well. I wanted you to explore how you're now integrating information from Voyager PAD and other data. I've kind of given you this heads up from our last conversation earlier this week, maybe. Yeah. But also I want to get a sense of how you would design, with that information now available, the next phase of your studies, because this is, you really just kind of uncovered the challenge of critical resistance, but now I think it deserves a fair bit of additional work. Definitely. And so I'm curious what you would propose if you had the ability to move forward with this line of research.
Yeah, most definitely. So just for the audience, Dr. Velasquez is talking about Voyager PAD that looked into aspirin plus placebo versus aspirin plus rivaroxaban in PAD patients who underwent lower extremity revascularization. And they basically looked at the composite endpoint of acute limb ischemia, major amputation, MI, ischemic stroke, and death. And they found that aspirin plus rivaroxaban had a decreased primary endpoint with a number needed to treat only of 39. They also looked at the safety from the safety perspective. And although there was no difference in TIMI major bleeding, there was a difference in the ISTH major bleeding. So we are going to incorporate this data, and we're going to form a Delphi consensus with all the major stakeholders. Because based on this, we're going to have a algorithm, meaning many of these patients are on anticoagulation. And so if they're on aspirin and anticoagulation, and despite the fact they are poor or intermediate metabolizers, we're likely not going to change them based on this information. And if they're not anticoagulation, but they're resistant to Plavix, then the discussion is going to go whether we should switch them to a newer P2Y12 or to Xarelto. And I'm more inclined into switching them to a newer P2Y12, mainly because this population was PAD and did include CLI, which was about 20% of patients. But CLI patients have a higher comorbidities, higher CKD, as I mentioned, higher platelet dysfunction. So my main concern is from the safety perspective, these patients can have a higher risk of bleeding if we put them on DOAC. So to answer your question, Dr. Velasquez, given some positive data elsewhere in the antiplatelet world, the first step we'll do in a Delphi consensus, we're gonna include interventional cardiology, vascular surgery, a pharmacogenomic group, and clinical pharmacy. And we're gonna reach a treatment protocol that everyone is agreed on. And once we develop this protocol, we can retroactively see if this makes sense, if the stakeholders are following the protocols, and if this have an impact on outcomes.
I would just add, that sounds great. I would add is don't be afraid to randomize. One of the really amazing opportunities we have within our organization is the capacity, since we're such a large system, to pragmatically randomize patients to different standards if those, so I think once your group has come together, it would be very interesting. Obviously, Kim would be very engaged, others, Carlos, Ed, others. But I think it would be wonderful to kind of to consider randomization as part of this strategy.
That will definitely be what we ultimately are looking for, or aiming. Yes, randomization and getting higher quality data there. Thank you for your comments. Anybody else have questions or comments? I'm happy to take.
This is Jeff Bender. That was a terrific, incredibly clear grand rounds.
Thank you.
I also agree with Carlos. You've been a great fellow to work with. So I have a question. I don't want to become infamous with the fellows as always being the one who asked the disease mechanism question, but I was very curious about the high rate of clopidogrel resistance in these patients. I mean, it's really high. And I wondered if you, Carlos, Kim, others are going to speculate. This is probably not answerable right now, but are going to speculate as to whether there's something else that this indicates, something about mechanism of disease. I mean, not even considering Plavix treatment, but something about gene linkage with CYP2C19 or something that co-segregates with this gene variant that it just seems really, really high in this population.
Extremely high. And yes, at this point, we do not know if CLI patients have at baseline a higher resistance and therefore develop CLI, or by the fact that they don't respond well to Plavix, they ultimately ended up developing CLI. It's unknown. I mean, we are considering working, with and looking into platelet functions and see if it's just at the antiplatelet level, is it's a genomic level. It's unclear. So these are all good questions that hopefully we're we will work towards answering. If you have more suggestions, I'll be more than happy to take them, because it's an unexplored, uncharted territory at this point.
Great, thank you. We'll get the geneticists involved too.
Oh, perfect.
Yeah.
Anybody else? Otherwise, I have. Thank you. Thank you, everyone, for joining today. Carolina says hi. And thank you all for listening, for joining. And it's been a wonderful 3 years. And I'm excited and can't wait to start my interventional cardiology fellowship as of tomorrow. Any other questions?
No, I don't think so, Phil. Thank you again. I want to highlight everything you said at the beginning, how wonderful and how much fun we had working together with the PV team. You're an outstanding clinician. We cannot wait to see how wonderful your coronary interventional year will be, but more importantly, your career. Thank you again.
Thank you.
For us.
Thank you. Bye.
Thank you. Bye.
Bye, everyone.